Hello, everyone, and welcome to today's Clinical Education Series presentation. Today's topic is mitigation of acute suicidal ideation tendencies. I am pleased to introduce today's presenters, Arti Patel and Sue Anderson. Arti is a pharmacist with over 20 years of experience and also holds a degree in psychology. She's been with Genoa for 12 years, starting as a site manager in Hackensack, New Jersey. Today, she serves as a pharmaceutical program manager with Genoa Clinical Services, where she leads initiatives that enhance patient care and strengthens partnerships across the healthcare landscape. Sue is a clinical pharmacy manager with Genoa Clinical Services. She leads a team of dedicated professionals and support staff as they help Genoa consumers navigate the first several months of taking certain newly prescribed specialty medications. Sue is also one of Genoa Healthcare's original certified instructors for mental health first aid. Since 2020, she has been helping Genoa team members at all levels hone their observation skills so that they can recognize and respond to mental health crises. Without further ado, I will pass the presentation over to Arti. Take it away, Arti.
All right. Thank you, Shannon, for that introduction. Hello, everyone. So today we'll be discussing the mitigation of acute suicidal ideation tendencies. Before we begin, I'd like to acknowledge that this is a sensitive but very important topic. Our goal today is to provide insight into risk factors, practical strategies for intervention, and resources that can support both patients and healthcare professionals when dealing with acute suicidal ideation. We hope this session will leave you with not only knowledge, but also tools you can take back to your practice or workplace to make a meaningful difference. I'd like to start by walking through the objectives of this presentation. So by the end of this presentation, you should be able to define and describe suicidal ideation and understand its public health impact. You will understand common risk factors and be able to describe intervention strategies, as well as be able to list support resources. These objectives will help guide our discussion and give you a clear sense of key takeaways we'll cover today. As we begin, it's important to recognize that suicide is a major public health concern with long-term impacts that extend far beyond the individual. It affects families, communities, and entire health systems. Let's look at some crucial facts. According to CDC data, in 2023, 12.8 million people seriously thought about suicide. 3.7 million made a plan, and 1.5 million attempted suicide. Of those, 95,000 died by suicide. That is one death every 11 minutes in the United States alone. Here's another interesting stat. While men make up about 50% of the US population, they account for 80% of suicide deaths. However, women attempt suicide more often. In fact, they are 1.5 times more likely to attempt suicide than men. But men tend to choose more lethal means, such as using firearms, where women are more likely to choose ways like intentional overdose of pharmaceuticals or exsanguination, such as wrist slitting. We also know, though, prevention is possible, and if professionals across disciplines play a critical role in that effort. Awareness is key. Knowing the signs of suicidal ideation is the first step towards saving a life. So, what is suicidal ideation? Suicidal ideation includes thoughts of death, self harm, or planning suicide. It can be active or passive, wishing to die. Passive ideation might sound like someone saying, I wish I could just go to sleep and not wake up. Whereas active ideation involves more direct intent and planning, such as researching methods or setting a date, actually making plans to die. It's a common misconception that talking about suicide or asking about suicide can put the thought in someone's head. This myth can potentially cause us to miss opportunities to prevent death by suicide. In fact, the opposite is true. Open, compassionate conversations can reduce isolation, open the door to treatment, and often play a key role in recovery. The fact is, often after suicide, friends and loved ones indicate they had no idea. But there are very often warning signs, and recognizing those signs gives us a chance to intervene before a crisis escalates. Identifying risk factors. When we think about suicide risk, it's important to remember that it's rarely caused by one single factor. Instead, it's usually the result of a combination of psychological, social, and biological influences. Mental health conditions are some of the strongest predictors of suicidal ideation. Depression is the most common, but PTSD, bipolar, and schizophrenia also significantly increase risk. It's not the diagnosis itself, but often the severity of the symptoms, feeling of hopelessness, and untreated illness that elevate the risk. Equally important are external pressures, things like abuse, neglect, bullying, financial stress, or social isolation. These create an environment where someone feels trapped or without support. Having social connections can be protective, so when those are missing or broken, the risk rises. So, here's another interesting fact. After 18 years of steady increase, suicide rates peaked in 2018. They started to decline in 2019 and 2020. Then in 2020, COVID happened. Through the COVID years, isolation became a big risk than it ever was previously. While we cannot say for certain that quarantining and COVID isolation was a definitive cause, but suicide rates were back to their peak in 2022. Then we also have biological factors that play a role. Individuals with a family history of suicide or certain genetic predispositions may be more vulnerable. Chronic medical conditions or chronic pain can further increase feelings of hopelessness and despair, especially when quality of life feels diminished. Keeping all of this in mind, it is important to note that having one or more of these factors does not mean someone will attempt suicide. But the more risk factors present, the higher the overall concern. That's why identifying them early is critical for prevention and support. Once we understand risk factors, the next step is recognizing warning signs. These are the red flags that may suggest someone is actively struggling and in need of support. There are people who may not display any signs or whose signs are subtle, but most individuals considering suicide will exhibit one or more of these signs. You may see changes in appearance. Sometimes these show up in small but noticeable ways, looking consistently tired, appearing disheveled, or showing a decline in personal hygiene. These changes may reflect a lack of energy or motivation. You'll see changes in behavior. You'll see changes in daily patterns, like coming in late, frequent absences, or withdrawing from social commitments, canceling plans, increased use of alcohol or drugs, or even giving away personal belongings can be a significant warning sign that should not be ignored. Additionally, you may notice a sense of depression or sadness, or maybe apathy or anger. Emotionally, you may notice withdrawal, a loss of interest in activities they once enjoyed, or disengagement from family and work. Mood shifts, difficulty concentrating, and indecisiveness can also point to someone experiencing overwhelming distress. Again, it's important to remember while risk factors show us who might be more vulnerable, warning signs tell us when someone may be in crisis right now. That is why recognizing and acting on these signs is critical. Now that we've discussed how to recognize both risk factors and warning signs, the next step is learning what we can do about it. To walk us through intervention strategies, screening tools, and available support resources, I'd like to hand it over to Sue.
Thank you, Artie. As we've heard, recognizing the risk factors and warning signs is critical. But once we identify them, the next question is, what do we do? That's where intervention strategies come in. One of the most effective strategies is also the most direct. Asking the question, are you thinking about suicide? Or are you thinking of killing yourself? Many people fear that asking this could plant the idea, but research shows the opposite. Asking shows care, creates safety, and often brings relief to the person in crisis. From there, the way we listen matters. Active listening means showing empathy, withholding judgment, and encouraging open conversation. Sometimes the simple fact of feeling heard and validated can reduce the intensity of suicidal thoughts. To better understand the level of risk, validated screening and risk assessment tools can help. Common examples include the Columbia Suicide Severity Rating Scale and the SLAP assessment, which focus on severity, lethality, access to means, and protective factors. These tools guide us in determining next steps. Finally, de-escalation strategies are about reducing immediate stress, providing reassurance, and helping the person regain a sense of control. Identifying protective factors, such as supportive relationships, coping skills, or reasons for living, can ground the individual and open the door to solutions. Each of these steps, asking, listening, assessing, and de escalating, work together to not only keep someone safe in the moment, but also to connect them with longer term support and treatment. If you notice signs of suicide, it is important to act. Talk to them privately. Never put them on the spot or embarrass them. They could very well shut down. You may not be the person they're comfortable with. That's okay, but start the conversation. Ask directly about suicidal intention. Don't ask if they're thinking about hurting themselves. That question is not specific enough for this conversation. In fact, they may see death as a way to end the pain, not as something that would cause hurt. Listen, let them talk, don't judge, don't tell them how they should act or feel. Let them get out as much or as little as they can or want. Be empathetic. Encourage them to access professional help. If you're in a professional capacity with access to risk assessment tools, use them. Here is an example of one of the validated screening tools mentioned earlier, the Columbia Suicide Severity Rating Scale, also called the CSSRS, or more simply, the Columbia Protocol. This tool is widely used in clinical and community settings because it utilizes simple, quick, straightforward questions that can be asked by anyone regardless of mental health training. The protocol focuses on key areas such as have they made any thoughts of suicide or made a plan? Then it assesses severity. The answers to these questions determine risk level and how severe or immediate. The number of questions depends on the individual's responses. You can use a tailored approach of 2 to 6 questions to quickly identify risk. Another tool is the SLAP assessment. S is for suicidality and specificity. Is the person indicated she or he is having thoughts, intentions, or made a plan to kill themselves? Lethality. Does the individual's planned method appear lethal, for example, taking a couple pills versus shooting themselves? A can refer to accessibility or availability. Does the person have access to materials necessary for their plan? And finally, P is proximity and people. Does the individual have close people near them? Have they shared these thoughts and plans with those nearby close friends and family? And do they have protective factors, such as a reason to live or people to live for? The goal in these assessments is not to diagnose, but to guide decision making, helping us to determine the level of concern, whether immediate intervention is needed, and how best to connect the individual to care. Importantly, tools like the Columbia Protocol and the SLAP assessment give us a structured way to have conversations that might otherwise feel overwhelming. They make sure we don't overlook critical warning signs and can help us as we attempt to de escalate the situation and keep them safe for now. Then stay with them and help them access help. Call 988 or the Trevor Project to connect them to crisis support. Help the individual identify their protective factors. Continuing with intervention strategies, there's more than one model for managing crisis. The 6-step model of crisis intervention by James and Gilliland, shown here, is another one of several available. It reiterates what we already discussed. This model helps guide conversations with someone in crisis in a clear, supportive way. Step 1 is listening. Defining the problem is to help the individual articulate the crisis concern. Use active listening, empathy, and understanding to help the individual define their challenge. Ensure the safety of all, the individual, yourself, bystanders. Conduct suicide risk assessments and homicide risk assessments, and control the individual's access to dangerous items if necessary. Provide emotional support, empathy, and validation. Offer care in the form of emotional support, instrumental support, and informational support to help the individual understand their options. The key here is to create a safe space where the individual feels heard. Once we understand the problem, step 2 is action. This step focuses on exploring alternatives, potential options, resources, and solutions with the individual. Help the individual explore new solutions and possibilities such as coping skills, situational supports, and additional assistance if necessary. Work with them to make plans to address the crisis and achieve healthy goals. Help the individual build realistic, achievable plans with clear steps to help them regain control. Get their buy in. Have them agree to the plan. This encourages a sense of responsibility and accountability. Ask the individual to verbalize their plan or even write up a document to confirm that they fully understand their plan. By following these steps, listening first, then acting thoughtfully, we can help someone navigate a crisis in a structured way that maximizes safety and provides tangible support. While it's critical to recognize risk factors and warning signs, it's equally important to identify protective factors. These are the strengths and supports that help reduce the risk of suicidal thoughts and behaviors. What are some protective factors? Access to mental health care, both preventative and responsive, is protective. Having someone to listen and support improves resiliency and can help develop problem solving and coping skills. Social connections keep those feelings of isolation at bay, and we know isolation is a risk factor. Faith or cultural communities that encourage connection help to protect an individual from getting lost in that isolation, whether real or perceived. Limiting access to means can be beneficial but hard. Once someone has confided or displayed their suicidal ideation, it can be hard but critical to ask, do you have a plan? Do you have access to weapons? May I hang on to your weapon or your medications or whatever the plan involves until you've gotten some help and feel better? By understanding both risk factors and these protective factors, we can tailor interventions to strengthen what's already working in someone's life and address what's putting them at risk. After recognizing risk factors, warning signs, and protective factors, the final critical step is connecting individuals to support. There are multiple pathways to help depending on the urgency and the setting. While in the heat of the crisis, there are several emergency resources, including calling 988, reaching out to the Trevor Project, and texting 741 741. If you perceive immediate danger to the individual, yourself, or to the public, call 911. Many communities have mental health crisis response teams. Always advise first responders if you know of or suspect a weapon. Encourage appropriate professional help, such as psychologists, psychiatrists, therapists, or other practitioners. Direct them to workplace support, such as employee assistance programs or other support policies, as well as community resources. There are also some good mental health care apps available with services covered by insurance. The key takeaway here is that there's no single path to support. The goal is to connect the individual with resources that best fit their needs, urgency, and comfort level while ensuring safety and ongoing follow-up. Beyond identifying risk and providing resources, prevention also relies on creating an environment that supports mental health and encourages help seeking. Just as we take steps to tend to our physical health with healthy practices and preventative health care, it is important to take steps to protect our mental health. One of the primary reasons people avoid mental health care is stigma. Doing everything we can to reduce stigma is a crucial first step to improving access to care. Awareness campaigns and open dialogues are two tools we can use to reduce stigma and normalize taking care of our mental health. Workplace policies that support mental health and stress management are also essential. Organizations can support employees by implementing policies that promote mental health, including flexible leave, access to counseling, and clear protocols for crisis situations. Encourage team members to use their PTO and protect their mental well-being. Providing training and education for staff, supervisors, and peers helps everyone recognize warning signs, respond appropriately, and know where to refer someone in need. Train employees in QPR, which stands for Question, Persuade, Refer, or Mental Health First Aid. Genoa Healthcare has a team of certified trainers who provide mental health first aid training to Genoa employees. There are other programs out there as well. Encourage and indulge in self-care. Hobbies, social groups, family time, meditation, yoga, exercise, all these activities improve resiliency and better prepare us to manage our stressors. By fostering a supportive environment, we not only reduce risk, but also empower individuals to seek help early and maintain mental wellness over time. Let's now walk through the first of our two case studies. Imagine this scenario. Case study 1, a coworker displaying warning signs. How do you respond? Jane has seemed down recently. You know she was upset about a presentation that didn't go so well. She's been complaining about her leg hurting, something about an old injury. Yesterday, she gave you her favorite pen set and her desk plant, and today she called out. What warning signs do you see? Jane is displaying a change in mood. We know she feels down about a presentation that went poorly. She complains of chronic pain. She gave away things of personal value. What do you want to do for Jane? Using the 6-step approach, we start with listening. We need to define the problem. Let her or help her articulate the concern. Is she embarrassed or despondent about the presentation? Does she indicate she feels like a failure at work and therefore at life? We must ensure safety. Is she safe? Ask if she's considering suicide. We should then provide support. Reduce her isolation by affirming she is not alone and you will help her get through this. Validate her emotions. After listening comes action. Examine alternatives. Explore potential options, resources, and solutions, such as 988 mental health professionals, 12-step programs, self-help idea. Call 911 if you feel she is in crisis or in immediate danger. Make plans. Work with Jane to help her make plans and set healthy goals. This can include offering to go with her to appointments or activities. And obtain her commitment. Get Jane to commit to these plans. Case 2, a client expressing suicidal thoughts. What steps should be taken? Josh has been a client for years. You have a pretty good professional relationship. One day he confides in you that something happened and he is just done, over it, wish I wasn't even here. What warning signs do you see? Josh is displaying a sign of passive ideation. He noted that he is just done and over it. It might be easy to brush this off or pretend you didn't hear it, but that doesn't help or support Josh through his struggle. Where do we start in order to help Josh? We can again use the 6-step approach, starting with listening. We need to define the problem, ask about Josh's concerns. Is he comfortable sharing it with us? We have to ensure safety. Is he safe? Ask if he's considering suicide. We would then provide support, reduce his isolation, affirm he's not alone. Ask Josh if he has any family or friends or clergy he can talk to. Let him know that you will help him through this. After listening comes action. Examine those alternatives. Potential options, resources, solutions, such as 988 mental health professionals again. Call 911 if you feel Josh is in crisis or immediate danger. Make plans. Work with Josh to make plans and set healthy goals, and then get Josh's commitment to see through health and safety. Make sure it's important enough to him and encourage him to commit to those plans. Through all of it, though, for both cases, remember to protect your own boundaries and mental health. You matter too, and it can be stressful and exhausting helping others through their low points and crises. Self-care is crucial. As we close, let's review the key takeaways from today. With 12.8 million Americans considering death by suicide in 2023, many of us have been touched by it in some way. In fact, in the time that we've been talking today, 2 people died by suicide. If this is a tender subject for you, please engage in some self-care after this session. Suicidal ideation is a major public health concern that affects all socioeconomic demographics, but it is also preventable with early recognition and timely intervention. We encourage you to explore training programs like Mental Health First Aid or QPR. They can help you sharpen your observation skills so that if or when you see the warning signs, you'll recognize them and act on them. Thank you for your time and attention to this important topic. Together, we can create environments where people feel supported, connected, and safe. Our hope is that you walk away with the confidence and determination to intervene when you notice and recognize signs of acute suicidal ideation. Please reach out to me, Sue Anderson, or to Artie Patel with any questions. With that, I will hand it back to Shannon to wrap up.
Thank you, Sue. Thank you everyone so much for watching today's clinical education series presentation. As a reminder, all recordings of our previous presentations are located on our YouTube channel at www.genoahealthcare.com/center-partner-resources. Our October presentation topic will cover Genoa Healthcare's role in HIV care with long-acting injectables. This presentation will be available on our YouTube channel toward the end of October. As always, again, if you have any questions, please feel free to reach out to Sue, Artie, or myself, and we will be happy to answer any questions that you have. Thank you so much and have a great rest of your day.